All right, so let's go ahead and get the ball rolling. Thanks, everyone, for joining us for the Lunch and Learn webinar series with Central Southern Ohio HIMSS. We're really excited to have you guys be a part of this today. Just a couple things to ask any questions during the presentation. You should see in the right-hand box there it says questions, and you can type those questions in there, and Kathy, who's on the call, will be helping us to bring those questions to light at the appropriate time. So please do ask your questions. The handouts that you're going to see today are also available for download. There's a handout section as well on the tool set that you can download these. And if you have any issues or you can't download it, just give us an email and we'll definitely get those out to you. We want to remind you about our website, and here's our email address for contact. And of course, I want to graciously thank our sponsors. It's our sponsors that make this all possible, that allow us to make these presentations available. And so here you can see a few of our premier sponsors. If anybody's interested in sponsoring, please do reach out to me. I'd love to have you join us as a sponsor. My name is Victor Simha, and I'm the sponsorship chair. And I'm just going to go through some of our sponsors here. You can see we've got quite a few. These are a great group of people. And also, you know, they're not only our sponsors, but when you need services that these guys provide, these are definitely people that I stand behind. I've worked with many of these guys for many years and would recommend any of them to help you resolve and troubleshoot and advance your business. Also want to touch base really quickly that our next conference is going to be Friday, October 13th at the Savannah Center in Westchester. It's right off 75. You can't miss it. So really hope that once that registration opens, you guys will all jump in and come to this event. Alex Valancourt, he's a CIO here in town, is our chair for that, and he is putting together quite the show this year. It's going to be really exciting. And also the 11th annual Ohio Day, OHIT Day. This has been going on, as it's the 11th. This is always a great event in Columbus, and you definitely don't want to miss that. And then, of course, our spring conference. We do 2 conferences a year. So in May 18th, we'll be in Columbus at the OCLC, another great facility. And we're looking for presenters for that as well. So if that's something that you're interested in doing, we're looking for keynote speakers. We're always looking for keynote speakers and presenters and lunch and learns. So please volunteer for those activities and help us get the word out. So lunch and learn. So Mike, I'm going to go ahead and turn this over to you and let you do your thing.
Let me. That's a beautiful picture of Chicago, which we'll be talking a little bit about Chicago today, because I'm a Chicago boy. So Victor, I can just start going now?
Yep, you're all set. Right.
Good deal. So thank you for that intro. So hi everybody, welcome and thanks for making some time over your lunch hour to chat with me about the thorny topic of payer-provider collaboration. Just a little note here. Of course, I'm working from home today, and of course, our streets and sanitation decided to rip apart our street and put in new sewers. So hopefully you won't hear too much background noise, but you may hear a little bit, and so I apologize for that in advance. But thank you for joining me. Talk about this topic. I have been living the topic of payer-provider collaboration now for the last 4.5 years on a project that I'm working on with my team, and I'm very much looking forward to sharing kind of what we've learned and kind of what we've heard, and hearing your questions and trying to understand what your thoughts are on this. First of all, I want to start by thanking CSOHIMSS for having me today. I really very much appreciate the opportunity to talk about this. Again, I've been living this and feel very passionately about connecting our customers and connecting the Ohio healthcare community together in new ways. Hopefully this conversation and a little bit about, the very little bit I'll tell you about Hyland and OnBase today, we'll do that. As many of you know, Hyland is based in Westlake, and 25-year-old company, very much a part of the healthcare ecosystem, and a sponsor of CSOHIMSS, which we're very proud of. So look forward to this conversation. My theme is building bridges, and I think that's really the center of the idea, right? How do we create new ways to connect payers and providers and other healthcare players, DME, home health, skilled nursing? What can we do to create bridges in a somewhat adversarial family relationship and in a very hectic healthcare environment that our government and the new administration has really created? There's a lot of uncertainty. So when we started this project, it was really all about building bridges, and I'll use that as my theme today to kind of talk through this. My name is Mike Hurley. I'm the Healthcare Industry Manager at Hyland Software. What that means is my job is to work with 150 or so healthcare payer customers, health insurance companies, health plans, really all around the world. We have something like 12 of the top 14 health payers in Ohio are our customers. So the payer market is something that's important, and I've been working with Hyland for 4 years to drive that. Before that, for the previous about 20 years, I was a consultant really focused on process automation for health payers, mostly Blue Cross plans, helping them use document management, workflow capture, and really other technologies to drive operational effectiveness. How do they help their members? How do they help interact with the other players in the ecosystem, and help the wellness and payment issues for their members? When I came on Hyland 4 years ago, they said, hey, that's awesome. Can you also help with our provider community? Hyland has about 1,600 to 1,800 health systems around the U.S., and so we've really been working on these bridges now since I started. How do we create effective collaboration between our customers? So that's me. I'm based in Chicago, so you're going to see some Chicago-based stuff. I usually use pizza as an analogy. I've really moved to bridges because pizza tends to be a controversial topic into itself. Some of my New York friends feel very strongly that somehow New York pizza is better than Chicago pizza. I don't know how that could be, but we'll go from there. So the agenda is simple. This was in the learning objectives that were put forth, and hopefully you saw before you registered for this conference. But really, just describing what is collaboration. Why is that an important bridge? What are the challenges to it? I'll spend a little time on that. That may be familiar. Perhaps you'll learn some new things about what the challenges are. And then we're going to talk about what the current state is. What's it like today? What are we seeing out there? I do have the opportunity to visit a lot of our payer and provider customers, which is the best part of my job because I really get to hear from people in the field what's going on. And we're going to talk about the future. What are we starting to see out there? What's going on, especially in Ohio? There's some really interesting new projects going on, some that we're a part of, some that standards committees are driving. We'll talk about that. And then we'll end up with some Q&A. Please, as Victor mentioned, please use that chat panel and offer your questions and comments along the way. If I say something that you strongly disagree with or agree with, or it drives a question, please enter that. We have left some time at the end to make sure that we covered that. So with that said, let's get started. If I can find the mouse here. There we go. Okay, so let's start with the bridge. In Chicago, this is the Michigan Avenue Bridge, as you can see, in 1869. This spot on Michigan Avenue in Chicago area is looking north, and as you can see there, that's the Mag Mile. If you've ever been to Chicago and shopped along our magnificent mile, you'll know that. And south is downtown, and this key spot connected the city in really unique ways. And even though this technology looks ancient in terms of today's perspective, right? At the time it was quite an achievement to span the river, and it really connected Chicago in new ways. It fostered growth. It showed technology as a key instrument by which Chicago could grow as a metropolis and as a center in the Midwest. Jump forward to 1920, that same bridge was rebuilt and rededicated, and it was quite a scene, as you can see up on your screen. But it was one of the most advanced technology and engineering feats at the time, offering 2 levels. Top level is pedestrian and car traffic, and then on the bottom level was all commerce, commercial trucks, commercial traffic, to really connect the north and south of the city in really new ways. As commerce was growing, as business was growing, as Chicago was growing as a technical and financial hub in the Midwest, it was really important to connect that. So that bridge, again, became a real important source of growth and of connecting and collaborating for the different parts of the city. And I always tell people that that bridge also helped connect Cub fans and Sox fans. I'm a Sox fan, if you were wondering, but it still serves that purpose. This is today. This is Chicago today. Hopefully you come to our beautiful city. Ohio's wonderful as well, but I'm very proud of Chicago and what a thriving city it really is today. And those bridges remain a really critical piece of our infrastructure, really efficient way of moving people and vehicles and commerce and bringing boats through the Chicago River there. It's really been a center of the city, an icon in many ways. What does this have to do with payer-provider collaboration? Because this technology really has withstood the test of time, and it's an example of Chicago's use of technology, and companies like Groupon and Motorola, International Harvester, that have really made Chicago their home. These technologies have lasted the test of time. They've really done quite well, even though they've lasted 100+ years. But as you know, not all bridges and technologies have lasted that long. And there's some technology, there's some collaboration technology that I'm going to talk about that really haven't lasted or fared as well as the Chicago bridges. So let's talk about collaboration itself. I want to start out with just a little description of what it is, how do people define it, and I looked around for a bunch of different definitions because I think we all intuitively know what collaboration means, but it's kind of hard to put your finger on it. So I went to a bunch of different sources, and I really found one that kind of jumped out. I'll read it a little bit and jump back to some of the key pieces. So according to this source, collaboration in healthcare is defined as healthcare professionals, so human beings assuming complementary roles and cooperatively working together, sharing responsibility for solving problems and making decisions that affect the wellness of patients. So a couple keywords that really jumped out and why I use that definition is complementary, human beings, first of all, people, working together in complementary roles, sharing responsibility, sharing decisions, sharing information to make decisions, and really collaborating on the wellness of a patient. I think that's important. I do think it leaves a little bit out, which is there's more to healthcare than just taking the care of the health, right, the patient. As we've seen in recent conversations in the press and media, that there's a lot of issues about the role of government, of payment issues, of audits, CMS and state industries, doing their part. There's issues of collaborating on chronic disease management for both payers and providers. How do we make sure this patient with diabetes and other issues is managed over the life cycle of their disease, and how do they manage that? The payers spend a lot of time on that, as of course do the providers. There's things like chart reviews for payers, HEDIS and risk adjustments that require collaboration with payers and providers to make sure that they're satisfying their fiduciary responsibilities, make sure that everybody's getting paid right and the proper people are paying. And then finally, there's this nasty issue of denials and appeals, right? There's the issue of collaboration around how do we make sure that the payment is reconciled properly, that payment is made timely and correctly and completely. It's really tough, and as you can see that I chose this image specifically because collaboration is really about finishing this bridge. It's really not done, And I think we'd all agree that there are a number of challenges. So I really wanted to move on to the challenges part. And I picked this image carefully too, because I think it's awesome. I think it's fake, but I think it's awesome to demonstrate the point. And it's kind of Escher-like. I don't know if any of you have any Escher drawings, but this kind of is one of those where the bridges just don't meet. And unfortunately, there's really no shortage of challenges for collaboration today. And while this image is intended to demonstrate, it's really not too far off, unfortunately, for a lot of collaboration in healthcare. We just miss the mark slightly, and over the course of miles, over the course of a patient's journey, we really miss that joining up to make the collaboration seamless and transparent and useful to a member or patient. So it's really hard. So why is this happening? I'm going to dive into some of the reasons and effects of the challenges of collaboration, but why it happens are numerous, right? There are a lot of reasons why collaboration is so challenging. One is simply the adversarial role of payers and providers. Providers are really focused on making patients well, right? Patient care, and that trumps everything. Payers are directed, their mandate is to manage the finances, manage the costs, make sure there's appropriate checks and balances so that we manage the care effectively, we're financing it appropriately, and that we have a mechanism within our country and within business to pay for that. It's a tough job for both parties, and that purpose can put them at odds, and it often does. And I think I think we'd all agree that probably is one of the key issues. I think government's shifting roles, another reason why communications challenges and collaboration is tough. The government continues to change the rules, sometimes monthly, sometimes more than that, and that's a real problem. Is something mandated? Do I have to do it? Is it a nice to have? Is it clear what we need to do? Is it clear the data and documents that need to shift back and forth? Often it's not, and that creates a lot of challenges on what should be shared, how it should be shared. So compliance, this issue of compliance and mandates from the government, really a challenge. And then why it's such a problem, I would argue, is technology sometimes just doesn't help. Technology sometimes stands in the way and causes a lot of challenges. And that's why I chose to focus on that. Like, what are the implications of the technology failures for collaboration? What's going on now? What do we think will be happening in the future? And philosophically, I look at this issue of collaboration as one of workflow. Of course, my career is steeped in the concept of workflow. I work for a company that does workflow as one of their key things. But how I look at this collaboration issue and this technology collaboration issue is really a technology issue around workflow. How do we get people working together? How do we take this from end to end? Not just the provider's workflow, and not just the payer's workflow, not the DME workflow, not the home health workflow, but how do we look at this end to end and solve the entire thing to the benefit of the member, the patient, the provider, the doc, and then finally the health system, or I'm sorry, the health plan that needs to pay for it. I mean, they all need to work together, and hopefully government fits in there to facilitate that. But I really do fundamentally, and the key thing I've learned in this over 4 years is it's really a workflow problem. We've got the workflow wrong, and the technology is not really supporting our workflow. So there are lots of challenges. I want to run through a couple. The first one is created by a guy in the 1840s. You probably don't know the picture of that guy on the left. His name is Alexander Bain. Alexander Bain was the Steve Jobs of the 1830s and 40s. He was a Scottish inventor and entrepreneur. Interesting guy, if you ever want to check him out. He, like Steve Jobs, he combined technologies to really create some interesting products. In the center there, you see a clock. Looks old, right? But at the time, it was one of the first electric clocks. It was created by Bain because he saw the possibility of combining electricity and timekeeping to really create something really interesting. What does that have to do with collaboration, right? Well, here's what it has to do. 2 years later, in 1843, he combined the telegraph, electricity, and chemistry, and he invented the first fax machine. And it was revolutionary at the time. It allowed armies and governments to move documents back and forth over telegraph lines in France, and really had an impact on wars that were waged at the time, on commerce, on political issues and diplomacy. The fax machine was a big deal in the 1850s and 60s, but many of us don't really realize that that technology is 170, 180 years old. It's really, really old. So why does that fit into healthcare? Well, while Duncan, commits that America runs on Duncan, the challenge for most of us is that our healthcare system, the most advanced, expensive, technically capable healthcare system on the planet, still runs on Alexander Bain's invention from 1843, which is crazy because it's not a technology. Unlike the Michigan Avenue Bridge, it is not a technology that has aged well. In fact, with a few changes, it really is not that different than the technology that Bain created a long time ago. And I think spending a couple minutes talking about what faxes in healthcare mean is probably some time well spent. So, faxes in healthcare, let's talk about it. First of all, most people don't realize that faxes are terribly expensive. Yeah, a fax machine isn't that expensive, right? And a phone line's not too bad, and you have to buy some supplies and paper, and that's not too bad. But what's really expensive are the people manning that fax machine. Even if you have e-faxes, people are having to manage them. Even electronically, it can be very expensive. A lot of our customers that aren't using OnBase for faxes are dealing with them in Outlook, or ending up printing them, or using their fax machine as a scanner to send stuff to their imaging machine or their EMR. It's really a crazy expensive tool that's really filled the gap, a technology collaboration gap for a long time. It's not secure. I was shocked to learn this some time ago, but faxes actually travel across the internet on voice over IP phone lines and can be hacked. There's not a lot of reported incidents of that happening, but they can be sniffed and hacked, and PHI is going across there, right? So we should all be cognizant of the fact that this whole technology is not very secure. We'd all agree that the image and data are very low quality. In fact, one of the key issues I think in the collaboration is sometimes people just can't read the text, can't read the fax. Is that a 1 or an L? Is that really the doctor's signature, or is that just some blob that somebody spilled some ink on the page? It's really hard to tell sometimes, and faxes do not help. There's very little data in terms of metadata, like other than a phone number, you don't really have any data that comes with the fax. And I call it throwing bricks over the fence, or throwing files, right? For the most part, what we're doing here is simply throwing files at each other and hoping they stick. But it's not collaborative. There's no real communication. That's why there's so many darn phone calls. Did you get my fax? Okay, you got my fax. When are you going to work on my fax? And that is not an efficient way. And I think what I've heard from my customers is really nobody likes the fax. I mean, I am one that does not like it, and we have technology that deal with it, but I think everybody really just loathes the fax. And I talked about cost. Let's talk about provider cost first. The MGMA, which I can never remember what that stands for, I'm not even going to try. Medical Group Management Association, I think. Anyway, they spend about, they say they did a survey of their members, an analysis of a number of providers, and found that on average it's $21, a little over $21 for a provider to handle a medical record today. That's expensive because a lot of these providers, especially large providers, a health system, can do dozens or hundreds a day. Cash flow. It does slow down cash flow. I think if there are providers on this webinar, I think you will acknowledge that it's gonna, a conspiracy theory exists that payers use, delays to slow down cash flow. I don't necessarily espouse that theory, but I understand why it exists. But my experience is that, no doubt about it, asks for medical records and for other documentation does slow down claims. It also, because it's slow, it's done. That same MGMA study showed that it was slow. It takes 2 to 3 weeks on average, because it's going via paper mostly because the records are so thick, it can result in a denial based on timeliness by the payer, which kicks off an appeal, which is also expensive on the provider side because now they've got to manage the receivables, manage the denial, manage the appeal. It's painful. On the payer side, I have to tell you, it's not any less difficult. There are a number of challenges on the payer side. It's expensive for the payer. These faxes that come in have to be dealt with. These paper documents that come in have to be scanned. Letters have to go out requesting additional information. It's really expensive, requires a lot of people costs, and it creates a lot of abrasion. What does that mean? Providers and members hate the fact that it's taking so long and it's so expensive, it's so difficult to coordinate this issue, and it just creates abrasion. People are unhappy about it. I was at a payer this week, very large payer in the Southeast, I asked about unsolicited attachments where the providers, and this is a common thing I hear, providers go, oh, I know when I get that deny code, I should just send a medical record because they're going to ask for it anyway. Well, that's an unsolicited attachment, and payers have no way of dealing with that because they haven't asked for it yet, so they don't know. So a lot of the reasons that this causes chaos in everybody, he said we don't know what to do with them, so we have to scan them and hopefully try to connect them. And there's a lot of people power, a lot of expense dealing with unsolicited attachments, just because there's not that coordination and collaboration around this issue. And then finally, the payers have to pay a ton of money to get charts pulled for things like care management and HEDIS and risk management, a bunch of issues around chart requirements that the payers need. They're expensive and they have to pay for that. So let's not forget about patient care, right? MGA said in that same story, I was just at CMS a couple weeks ago, same thing. Payers are requesting more and more records for a variety of reasons. The first one is prior auths. So for prior auth, 90% of the physicians said mostly, sometimes, often, or always, it's delaying care, which is not great, right? We do not want, in 90% of the circumstances, our care being delayed because of a collaboration problem. Finally, there's this continuing need for value-based care. We're moving away from fee-for-service to value-based care. So how do we improve that care coordination between payers and providers? How do we support alternative payment models and a variety of methods that are being created and tested to help payers and providers work more collaboratively together? And I just thought this stat was just astounding. On average, 37 prior auths a week per physician, resulting in 16 hours of staff time to deal with it. That's expensive. If you have a small doctor's office, I won't go into the story, but I interviewed my personal PCP for this project, and he's like, yeah, you wouldn't imagine the amount of effort, and he kind of showed me some of it. It was horrific. So lots of effects to patient care. And I just have one more set of challenges. I'll just build this out real quick. That there really are no standards yet. Folks I just got off a call previous to this one with another association that's trying to move forward standards, but CMS has not adopted them, the federal government has not, and it's unclear where the Trump administration and HHS and CMS are going to go to foster standards. It's really unclear. Some of them, some amongst us that are a bit more pragmatic or cynical, depending on how you want to look at it, or skeptical, I think we might be still some way away from an EDI standard, unfortunately. But payer charts are lost. A lot of that's around unsolicited stuff. They get sent to the wrong place, or payers don't know what to do with it. So they'll actually request the same chart several times for different reasons. So there's a lot of problems with coordination on the payer side, which creates discontent and challenges on the provider side. While everybody agrees, the post office, sending stuff to the post office is absolutely the worst. Faxes are only slightly less worse, and portals are really not much better. The providers that I've worked with to talk with about this issue to say that they might have 10 or 15 different login IDs and passwords to portals just to upload a document to try to get a payment issue resolved. So it's really challenging on the provider side as well. And then this issue of quality, the number one issue I get from payers is that it's just tough to read this stuff. You've got some nurse trying to make a decision, and the images and the data are bad. So the system's incomplete, right? So there are a variety of methods. I wanted to use an image that was scary and at the same time showed promise that hopefully these two bridges will connect. But could you imagine going to work on a Monday morning and doing that job? I just cannot imagine being at a height. I'm a little afraid of heights, so that kind of freaks me out. But how do we do it? What do we do today? How does it work? What's working, what's not working? So I want to spend a little time on the current methods on how people are collaborating today. So I'm just doing a quick chime check there. So I love this quote. I listened to a podcast recently that was awesome. It's called Healthy Dose. You can find it in whatever way you want to consume your podcast. But it was really awesome. These two venture capital guys interviewed this guy, Rich Roth from Dignity Health, who's got a great title, right? Chief Strategic Innovation Officer. Really interesting dude. And he had this sentence, and I'm like, hallelujah, somebody gets it. That while culture is really important, culture eats strategy for breakfast, and there's a lot of strategies around how to get collaboration working, but ultimately it's a workflow problem. It's not a fax problem. It's not a payers losing my chart problem. It's not a payment problem. It's not a patient care problem. It's a workflow problem. We need to get the workflows connected. And I love that he said, workflow eats everything, and I totally agree. Why the fax machine is still around today is because providers and payers can make it part of the workflow. They can make it work. It's ugly. It's awful, but workflow eats everything. I got to get my job done. I got to get patient care done. I got to get this claim paid. So that eats everything, and I really think that's just an amazing quote. I love that quote. In fact, tonight I'm posting a blog post about that. If you don't, I'll give you my LinkedIn address after this. I'd love for you to connect with me on LinkedIn and see some of my posts. I've been blogging on there for a while now. But what are the methods? What are the bridges that people are building today? Well, these are what I see out there as the different methods, and I'm going to spend some time on it, but I just want to explain them first. So if you agree with Rich Roth and workflow eats everything, and if you agree with me that this is really a workflow problem, not a technology problem, not even necessarily a human, people problem, I believe it's a technology, and that technology, it's a workflow problem. And why I say that is there are really three different workflows at play here as I can kind of construct the world. The first one is manual, right? Paper goes out in an envelope, it comes back, it's opened, it's scanned. Paper, snail mail, fax isn't really that much different. A lot of places faxes end up as a piece of paper. So there's some secure email, but I'm not really seeing much of that. That's as difficult. Having to log onto a portal, download your email, or read it, it's problematic. I think you'd agree. It's not very collaborative. So these manual pieces are duct tape and baling wire, right? They're ways to get through it, get it done. Very expensive, affect patient care, not optimized, but that's what we got today to get our job done, because workflow eats everything. There's a movement to semi-automated methods. Some years back, I think it's now 10 years, ESMD came about. If you're not using ESMD, it's a model for Medicare. But very low adoption, unfortunately, the ESMD. I think ESMD was a great idea that just didn't catch on. But the idea is to be able for a provider to send their information back via PDF in some structured way. Portals seem to be the leading area where payers are investing for semi-automated. I say semi-automated because at least a piece of paper doesn't have to go through our mail system or fax system to get there. But portals, as we've talked about, are equally wicked and diabolical in their own ways. I'm not a fan of portals. They serve their purpose, I guess, sometimes, but they're painful. And I have a password safe to manage all my different portals, and it's still painful and difficult to deal with portals. And then every portal's different. If you go to an Anthem portal, it's different than a Medical Mutual portal, which is different than a CareSource portal, which is different than a Humana portal. Just different ways, different things. Plus portals, I know I'm going off on portals, but it's just really challenging because different rules for different portals. How much which things can go where, how much, how many, it's very difficult. And then there's direct messaging out there, and some people are using, file sharing websites like Box and Google Drive and Apple Drive to share files. Not secure, not HIPAA compliant. So hopefully that not too much of happen. But I do see those vendors out there trying to make a claim that they're HIPAA compliant. They're not. So they're semi-automated, and then finally there's automated, right? Which is really what we want to get to. How do we tie these systems together? And the current EDI standards are out there are the X12 standards and the HL7 CCDAs. You may have heard of this transaction. It is proposed. I was just at a little meeting at CMS in Baltimore about it in the middle of July, and we are no closer today, I'm unhappy to say, to that EDI standard than we were probably 10 years ago. And there's still lots of technical challenges around it. There's committees that are dedicated to making that better, and I salute their cause. It's really about creating machine-to-machine workflow between payers and providers, just like claims and some prior auths go today, and eligibility, some X12 transactions. We have a long way to go. The adoption curve is going to be challenging, but it's one of the automated workflow methods. But it only gets us organization to organization. I'll talk a little bit about Mackinaw. Mackinaw is a pilot we've got going on in Ohio that goes into production next month, which connects payers and providers through automated workflow. So this isn't a commercial presentation, but I thought it'd be good for you to see it, to kind of see another example of what automated workflow might look like in the future. So those are different methods by which payers and providers are collaborating via workflows. I would have to tell you that manual and semi-automated are not collaborative. Even EDI is not collaborative. It doesn't allow conversations. So we'll talk about how I think that's going to roll in the future. So just talking about solicited medical records requests, which is the kind of topic that is of great interest to the EDI standard today, I just wanted to walk you through really quickly how that works today. You probably know it, but you may, if you're a provider, you probably only know one side of the transaction, you might know the others. On the payer side, if you start in the upper left-hand corner of the screen, you see that they're requesting they're creating a document that requests medical documents for a particular claim. It goes to the print shop, the mail room, then it might go to a postal service truck or a fax machine, depending on the urgency or whether it's prior auth. It ends up in your mail room or on your fax machine, and then ultimately it gets sorted, prepped, and scanned, delivered to the release of information department that will go to their EMR. They'll create a beautiful PDF, which of course they'll print out, send to their mailroom, who will either fax it or mail it, and then oftentimes that'll come in, if it comes in via paper, it'll go to a mailroom, they'll sort, prep, and scan it into their imaging system, then they'll deliver it either via mail cart or automatically via workflow to a work basket, where a claims examiner at the payer will go, yep, a nurse needs to see this, send it off to the nurse, who will then approve or deny that claim. So too many boxes, too much going on, takes a long time. Our focus group showed about 12 to 18 days just to handle this, from the time the letter's generated to the time it happens. That's the happy path, and there's only 30 days in that window. So if something happens on the postal side or on one of the mail rooms or somewhere in one of these boxes, it could quickly time out, and we'll talk about that in a moment. So that's a process that we've been focused on for some time, and that we're spending a lot of time on right now. So while I hate my little images, and my marketing people are probably cringing if they're looking at this, I just wanted to say, what are the pros and cons of these different methods? So I want to talk about manual first. I think this goes without saying, but I just want to pause and say, if you have any questions or comments on this, I'd love to hear your comments about manual. I've heard some very colorful comments, but the good thing about it is everybody has access to it. It's really simple. I know the fax machine it's plugged into. I can hit the memory 1, and that's Dr. X, or that's payer Y. Everybody understands how to use it. It provides a flexible workflow for me, which is probably the key thing. So that's why people use it. I think they also perceive that it's less expensive. But on the real side, on the thumbs down side, it really is quite expensive, as I described before. The quality is terrible. Security is not good. There's no way to check if anybody got it, so a lot of people call. And it's not collaborative. I can't go, did you get it? Like right within the fax, I can't confirm delivery. I can't, you know, if I receive a fax, I can't immediately just go, hey, I got this, but I don't know why are you sending me this? So there's no conversational or collaborative aspects on it. On the semi-automated side, we got similar but different problems. It's a little bit more secure. Portals are much more secure. You're uploading documents, so those have much higher fidelity. It's maybe faster, and may work with the payer's workflow. But on the downside, on the provider's workflow, it's awful. And I hear this time and time again as we've kind of interviewed providers on this. It requires IDs and passwords. It mucks up the workflow. If I'm going to try to create direct messaging or ESMD or something else, it's going to require an IT investment. It's not very flexible. It is still expensive because I have to have people do it. I still can't really collaborate or have a conversation. I'm just throwing another document over the fence. And there are all kinds of limitations on the number of attachments, what size they can be, what types. So, you know, I'm still not a fan. I know a lot of my payer customers are using portals. I'm just not a big fan. So let's talk about the automated side. I think there are a number of pluses and some minuses here. On the plus side, it's going to reduce costs. It's going to bring that 2134 down to probably 10% or less of that cost. It's highly secure because you're leveraging existing secure infrastructure. High fidelity documents and data. It's much faster. We're saying like 1 to 3 days versus 12 to 18. It works with provider and on the Mackinaw side it does. On the EDI side, not so much. It still requires some workflow to be created. EDI is not so collaborative and conversational, but it can be combined with other technology. On the Mackinaw side, we've definitely built a collaborative platform. And then on flexibility, the EDI is going to require some IT investments to create that flexibility, but it's a great, assuming you can cover those things, it really can be a flexible model once fully adopted. On the downside, not everybody's adopted it, not even CMS, not the federal government, nobody's mandating it, so nobody's doing it. The payers aren't doing it, providers aren't doing it, and it's really a challenge for many of our customers. It does require a significant IT investment, which really hasn't been fully fleshed out on what that costs. And your IT people, most of my IT customers, or most of my customers, their IT departments, have stuff to do, and this would be yet another project. And it requires adaptation. So one of the things that when we started the Mackinaw project 4 years ago, we were really saying, how can we complement the EDI standard as it comes along, but also create a collaboration to do that. So what does collaboration look like in the future? And I wanted to give you an example as we kind of wind down here on what's an example of true collaboration beyond simply throwing files at each other, manual and semi-automated workflows. How do we create a true conversation about patient care and about patient payment and about authorizing care and services and drugs? How do we do that? What does that look like? And I think I found this picture. I love this bridge. I hope it gets built someday. I think it's really, really cool. But we need to start building really futuristic bridges to help people collaborate better in the future. So with Mackinaw, our model, I just thought I'd kind of walk you through very quickly, not in a just an educational perspective, how this might work, right? So payers can create that letter that they're requesting and attach it to an e-form. That e-form can be encrypted in an XML file and passed along a couple clearinghouses, wind up right in the workflow of the provider in the release of information team. They can still go to their EMR, but attach that PDF right to that e-form and send it back via the clearinghouses or HISPs right back. And all the while, you want to keep track of, did they get it? What's the status? Are they in the phone book? What kind of admin? So you want to create a collaborative thing that allows us to really do this in 1 to 3 days. And so what does that look like? People always ask, what does an e-form look like? I don't think it's that dramatic, but this is an example of a Mackinaw e-form that the provider would fill out, and they can attach and comment, but this information is filled out right from the payer system. And on the provider, when they receive it, it comes right into a workflow queue. So workflow eats everything, right? So people want to go to their EMR and then attach those documents right into the form. They click on submit, and those documents are attached. They can also request initial information. How do we create the collaboration? Comments. Hey guys, I got this, but I didn't get this. I need that. Okay, here's this, but we need to confirm that. So we really wanted to create a situation with Mackinaw that allows a conversation to happen around wellness and payment issues. So and it shouldn't matter just because you're using a particular portal that you have a document that's 3 gigabytes, because it has a bunch of scopes and EKGs and images in it. You should be able to just send anything. So any number, any documents, any type, whether it's a standard type of file, an HL7 file or not, we're going to let our customers send everything back and forth. So when it comes back to the payer, they get that form. They can simply see those attachments, automatically save them into their system and review them. So there's really, I think workflow is requests are created in the native way that a payer works. Requests are satisfied in the native workflow that the provider uses, which is their EMR and their Epic or Allscripts or patient management system, right? They're using that same system. They're attaching those documents, whatever they've got, and they're sending it off. And I think ultimately that'll get more and more, more and more robust. And as EDI standards come about, this will be a complementary. These kind of workflow models will be complementary to the standards. Looks like I'm running up on almost out of time. It's 11:48. I want to leave time for questions. So looking forward, where our workflow is going, it's not just about claims, right? It's about prior auths and appeals and HEDIS and risk adjustment and managing and coordinating care and utilization management, claims, care management, disease management. On the provider side, they have a lot of things that they want to focus on, especially care coordination and continuity. And then there's a bunch of other areas that we're exploring right now that I think really hold promise, because workflows are not just bidirectional, they're tri-directional and multi-directional, as you know, and hooking them all in a workflow that allows them to collaborate really, I think, is the key thing. How do we bring more people in, more use cases, more workflows, so we really can eat everything and really solve this problem for both care, cost, and other issues. So hopefully we covered what collaboration is, what the challenges really are, some of today's collaboration workflow technology, if you want to call it that, manual, semi-automated, and then of course digital workflows, which are really taking us in the future and building those future bridges. So I'm going to ask my collaborators here if they got any questions in. I did put up some questions, but I just wanted to throw up a couple potential questions. Kathy, did you receive any questions or comments along the way?
Hi, Mike. Great job. No, at this point, I don't have any questions. So if you'd like to go through your questions, that would be great.
Okay, cool. Well, I hope I didn't put people asleep, but or maybe I answered all their questions, maybe the optimistic view. So the most common question I get from folks is, all right, when is CMS going to require the EDI standards be enforced and mandate compliance? And I will tell you that if I knew that question, I'd play the lottery tonight. I hear the numbers like $300-something million. I have no idea. I don't think anybody does. I will tell you that it does not require a rocket scientist to look at the nightly news or read a paper to see that with the change in administration, there's a very negative view of adding additional burden to businesses, and so compliance, new regulations are frowned on. In fact, if a new regulation like this were to happen, 2 others would have to be deleted based on the current laws. I just think that's going to be tough right now. I hope and I support, and we continue to attend events and try to push forward the EDI standards for 275, 277, 278, and HL7 stuff. I think we got a long way to go. It's going to be really, really tough. And I think other workflow products are going to have to step up to fill that void until that ultimately happens, because it might be 4 years off still. unfortunately. The Mackinaw project has been a 4-year effort to help figure this out for our customers. We have over 80 health system and payer customers in Ohio. I'm happy to say that in less than a month we go live in production in Ohio for our on-base customers who actually own Mackinaw already. Our payer customers have about 80% of the insured population in the state, so we think it'll be a good test case for Mackinaw going national. It is complementary to the 275 standard, so we're very happy that we were able to come up with a piece that allows that complementary piece. But I'm most satisfied that our customers in less than a month will be able to solve this solicited claims attachment, and then we're working on appeals and prior auth next. What have I learned? This is a really difficult iceberg to break up. It's really tough. As I mentioned, the biggest thing I learned is this is really a workflow problem, and workflows right now happen with human beings, and we want some of that workflow to go to systems and robots in the future, but right now, we're not there. We've got some ways to go. The other thing I've learned is that I think we have to take it upon ourselves to act. I don't think we can wait for an IT government mandate to drive this. I think we as healthcare actors and ecosystem participants need to take responsibility for this and make it happen. I think it's really up to all of us to play our part, and that's why we started this project 4 years ago. I want to throw my information up there while I kind of wrap up and summarize. Please feel free to email me or connect with me via LinkedIn. I do tweet periodically, probably not as much as I'd like, but that Twitter account is my own. It's not a Hyland-based account, so be careful there. But I will say thank you very much for attending today. I hope this is valuable. If you or your organization would like to talk about collaboration a little bit more in depth or more personally about what type of collaboration you'd like to help foster within your ecosystem, we're absolutely happy to participate. Even if you're not an on-base customer, chances are if you're one of the large health systems in the state or one of the large payers, you're probably using on-base today, and we'd love to come in and meet with you. But if you're not, we're happy to talk. We'd like, even if you don't have on-base, you'd be able to participate in the Mackinaw network. So we're happy to talk. I want to thank Victor and Kathy today, as well as the others at the CSO who allowed us to be a part of this. We thank you for your attention and look forward to engaging you in one of these social vehicles or via email or hopefully in person someday. So thanks again, and Victor, I guess I'll turn it back over to you to wrap up if you care to, or Kathy.
Victor, you can go ahead if there's anything you need to say.
I think Victor might be on mute. So maybe Kathy, I can just wrap up by saying thank you to all the participants. This has been recorded. I see the recording light on. So if you would like to share this or share the handouts, please feel free to do so. And again, if you have any questions on the CSOHIMSS side of things, please feel free to contact Scott Nash or Victor or Kathy on the CSO and HIMSS related stuff. And please feel free to contact me or my associate Colin Gibb to answer any questions on Mackinaw or on payer-provider collaboration. So thanks again today. Have a great afternoon, and thanks for joining us for this Lunch and Learn.
Thanks, Mike, and thanks everyone else. Have a good one. Bye-bye.